Okay, well, hello everyone, welcome. My name is Audrey Gay. I use she, her pronouns, and I'm the organizer on the staff team at the BC Health Coalition. Thanks for making time to be with us today over your lunch hour. I just want to start by grounding ourselves and acknowledging with gratitude that I'm joining today from the unceded Coast Salish territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And today we're talking about extra billing, which is a topic that's really kind of tightly connected to the history of the Canada Health Act in Canada. And as public healthcare advocates, we like to brag that our healthcare system is based on need and not the ability to pay. And the fight for extra billing to end in Canada is a big part of that. But it's also helpful to remember as we're having that conversation that the ability to pay is not the only barrier to equitable access to health and equitable health outcomes. And we know that colonization and Indigenous specific racism, social determinants of health all have a lot to do with equitable health. So we're going to be focusing on one aspect of equitable access today, but I want to start by reminding all of us that there's much more to it than that. So a few housekeeping items. I'm going to repeat myself about the recording just because there's some new people joining us. You can choose to turn your video off and rename yourself if you're concerned about your confidentiality on the recording. This session is being recorded and will be posted publicly as a resource for the rest of our membership. And because this is kind of a regular Zoom meeting format, I'm going to ask everyone to please stay on mute unless you're speaking. And I do have the ability to mute you if you forget and there's some background noise, and that just helps keep the sound clarity clear. So I'll share my screen just really briefly and go over some just introductory stuff. That's the wrong date. Well, if you're new to the Health Coalition, our mission is to defend our healthcare system against privatization and to expand Medicare as the public healthcare system to include things like pharmacare, dental care, vision, extended health, one day public mental health care, as well as working on evidence-based public solutions. And we do that in three main areas of work. The first is generally anti-privatization. Another big area of focus for us is seniors care, including long-term residential care and at-home community care. And then primary care reform, so that everyone has access to primary care and can have the best chance of staying well instead of being treated when they get sick. We're just in the second session of Visions and Solutions in Healthcare Lunch and Learn series. So we had one session 2 weeks ago about community-led primary care solutions, and that session, if you missed it, the recording is up on our website, so you can go ahead and get caught up if you'd like. Today we're talking about extra billing, and you'll find out a lot more about that shortly, so I won't waste time talking about that. I'll let our great panelists do that. Just to give you a sense of where we're going, we're going to get a chance to meet our two guests today, Andy and Saad, in just a moment. And then they each have kind of a presentation to talk about extra billing. So Dr. Saad Ahmed is giving us more of an overview of extra billing and a recap of the fight against extra billing here in BC. And then Andrew Longhurst is going to be diving into what the situation looks like currently in BC and what can be done to put an end to extra billing. Hopefully we'll have a good amount of time left over at the end for a Q&A, and we're going to do what we can to answer everyone's questions and have a good discussion. So if you're not already connected, please head over to our website, bchealthcoalition.ca, and find a way to be involved in this movement that's meaningful to you. And I think that's it for my quick spiel and plugs. So we'll get started, I guess. And first, before we kind of dive into the meat of the conversation, we want to meet our panelists and hear a little bit about them beyond the specific interests and extra billing that they bring. So the question is going to be the same for both of you. I'll start maybe with you, Saad. Can you tell us a little bit about yourself and your background and how you ended up doing your current advocacy work?
Yeah, no, thank you for having me, Audrey. And it's a pleasure to be able to talk to all of you. You guys can hear me, right? 2 thumbs up.
You
Everything's
sound
working.
great.
Okay, perfect. So yeah, I'm a family doctor here in Vancouver on these unceded territories, and um, I think I'm more than a family doctor. I'm a husband and the father of a 7-month-old baby girl, and so a lot of the discussions around access to healthcare and ensuring equitable access to healthcare really strikes home. Grew up in a working class family, and there was a lot of times in my own childhood where perhaps my dad didn't have work, and when we went in for healthcare, it was just that was one thing that wasn't a source of stress. So I think that's really, if I'm trying to root myself in why I've ended up joining the Western Board of Canadian Doctors for Medicare. It stems from a lot of that work, and then also the clinical work that I've taken up over time. Um, I am here on behalf of Canadian Doctors for Medicare. I do have a role with Vancouver Coastal Health and the medical director of homelessness and supported housing. Not putting on that hat today, but it certainly informs sort of why I care deeply about access to healthcare and health equity when there's so many folks who are marginalized who may not be able to get access when we create financial barriers. Yeah, it's a little bit about me.
Great. Well, thanks for being here. I look forward to hearing more from you. Andy, over to you.
Thanks, Audrey. So I'm coming to you wearing a few different hats. My pronouns are he, him. I'm currently a co-chair of the Anti-Privatization Working Group of the BC Health Coalition, along with Colleen Fuller. And I've been involved with the BC Health Coalition for many years now in various capacities. One is as a health policy researcher with a public sector union, healthcare union, and I also do work as a research associate with the Canadian Centre for Policy Alternatives. And I'm also currently working on a PhD at Simon Fraser University that is looking at not directly extra billing, but actually primary care reform. So all of these issues are near and dear to my heart, and I think just as many here care so deeply about Canadian public health care. I actually grew up in the U.S. and can tell you all about the experiences of U.S. style healthcare and the problems therein. So I'm here as a strong believer in a publicly funded and not-for-profit delivered system, and looking forward to diving into the discussion today. And thanks for the invitation.
Great. Well, good to have both of you. I always prefer hearing directly from people instead of reading off a bio. So I thank you for introducing yourselves in your own way. I appreciate that. I just wanted to, I'm going to hand it over to Saad in a moment, but I want to just to the rest of our guests, invite you to use the chat throughout the conversation to post any questions that you might have for the Q&A. So kind of as they come up for you, we will wait until the Q&A to kind of go through them, but that will help me plan to moderate that Q&A a bit better, and it gives you a better chance of your question getting selected if it's sent early on. So I'll encourage you to do that as we get going. So Saad, I'm gonna start with you and really like for everyone, I invited Saad, who's yeah, as he said, on the board of the Canadian Doctors for Medicare, to really give us a bit of an intro to extra billing. Like, what is extra billing? What's the history of extra billing in Canada, and how is that connected to what we're seeing today? And then, because the Health Coalition and Canadian Doctors for Medicare for many years were co-interveners in the Cambie case, which was essentially in large part about extra billing. So it's going to give us a bit of a recap for that as well. So thanks so much for agreeing, Saad, and I guess the mic is yours.
Yeah, no, once again, thank you for having me. I think, with this discussion around extra billing, it's important to start off by defining extra billing and also explaining what it's not. So, I mean, I'm going to use probably the clearest definition that I've found, and it comes from the government's or Health Canada's own report, where they have a pretty lengthy appendices on extra billing and actual dollar amounts, and we can get into that with the context of British Columbia. But really, extra billing is defined as a charge by an enrolled physician or dentist to an insured person for an insured service, so an insured healthcare service under the medical services plan, that's in addition or in excess of the amount that's paid by that plan. So really, to kind of, as I'm saying, like, to really keep it simple, it's, let's say your family doctor gets $30 to see you for a visit to their clinic. Extra billing would be them charging on top of that, on what they would normally receive from MSP. Now, this is different than user charges. So, this is really user charges themselves. It's like the government's definition is an insured health service, like charge for insured health service other than extra billing. But it could be, if you're at like a private surgical or diagnostic clinic, that you're being charged for that. Or if you're getting any physician-related services that are provided in conjunction with an insured physician service at a private facility. So once again, it's often the example is used of a diagnostic clinic or a private surgical clinic. And so, when we think about extra billing and the discussion around illegal extra billing for our purposes today, really we're going to focus on that piece. It's where folks are being charged above and beyond what the insurance plan normally covers. And I can see, Andy, in terms of the agenda, we'll talk about a specific subsection of the Medicare Protection Act and enforcement around that, and we'll get into the nitty-gritty of that as well. So yeah, really, extra billing, user charges, two related but separate things. In British Columbia, we're looking at about, and based on Health Canada's methodology, looking at about $5.8 million in extra billing charges. So it's not an insignificant amount. And so the way that Health Canada has dealt with that historically in order to support the tenets of Medicare is they will often claw back the set amount from the provinces that they calculate based on their methodology as a kind of as it is punitive in a sense that you're not upholding the tenets of Medicare, and as such we're going to dock you for charging folks however your system is working out that way. Extra billing, I mean, obviously prior to Medicare there was no set rate in terms of insurance, and at least the context that I know really well, because I grew up in Ontario and trained in Ontario as well. There was a lot of fights. There was actually a notable strike in the 80s, actually 1986, where Ontario physicians walked out because there was a ban on extra billing at that time. And unfortunately, that strike kind of blew up in the face of the doctors who participated in it, and there was not very much public support for it, and it was very clear to all parties involved that this was creating challenges to poorer patients and people who couldn't pay those kind of fees once again on top of what Medicare was reimbursing. But there's other ways that has kind of continued. And so I think once again, the thing that we're going to talk about is around diagnostic services. And, BC has had a plan around extra billing for diagnostic services. In fact, the Medicare Protection Act in 2003 was amended to include a subsection 18.1, which basically the original subsection, I don't want to go into the legalese of it, but basically was saying that, that once again, that you're not being charged by a medical provider above and beyond what should be covered by Medicare and by MSP. And then there was definitions of what where that subsection applied to. So hospital, facility, community care facility, medical facility, et cetera, et cetera. 18.1 specifically was brought in to talk about diagnostic facilities. So an approved diagnostic facility or diagnostic services in a hospital or some of the other places like regional health boards in this nation or the provincial health services authority. So really being an all-encompassing definition. And it was brought in 2003, and it has been punted well over a decade in terms of enforcement. So really when we're talking about illegal extra billing, the discussion is particularly around the enforcement of Section 18.1 when it comes to diagnostics. And so to be really practical about it, because as I said, I don't want to go into the legalese, where it comes down to it is that there's folks who are being charged above what MSP covers for an MRI or for a CT scan or an ultrasound. Usually it's that an MRI and a CT scan, right? And so the feeling, because the federal position is that patients should not face charges for medically necessary hospital and physician services, including diagnostic services, regardless of where the service is provided, right? That's the portability aspect of the Canada Health Act. So I can see there's some comments and stuff here, and I can clarify those in a sec. But really what we're talking about with illegal extra billing is that there is a law on the books in BC around not charging patients for MRIs and CT scans. That practice is ongoing. I just cited the numbers earlier. And there's a concern that this is allowing people to essentially skip the queue. And so that we are rationing access to MRIs and CT scans on the basis of ability to pay and not on need, right? That's really what it comes down to. And so the federal government, to their credit, has been issuing a fair number of letters and in a specific policy statement, April 1st, 2020, the Diagnostic Services Policy Statement, that they are essentially telling provinces that we're going to eliminate patient charges for medically necessary diagnostic services and that they're going to enforce it, the Canada Health Act. So this is where I think really, the discussion is happening in BC, because there have been letters issued to all the provinces with that policy. What are you guys going to do about this? This essentially illegal extra billing that's happening, particularly around diagnostic imaging like MRIs and CT scans. Provinces have had a chance to respond, and so BC has come up with a plan. And so in 2018, they said that they were going to, work on those remaining provisions of Bill 92 to bring BC into compliance with the Canada Health Act. There's a bunch of stuff that they included. So they're going to fine physicians or clinics that were found to contravene the ban on extra billing, $10,000. Second strike would be $20,000. The Medical Services Commission could cancel the enrollment of a practitioner. So there's a bunch of punitive abilities that the provincial government here has brought in to try to bring us in compliance with the Canada Health Act. And the enforceability of that, I know, Audrey, you talked about, well, what about after Cambie? Well, that was challenged in Cambie Surgery's corporate versus British Columbia. And then, basically now that has gone to the Supreme Court, we are in a good place to be able to enforce that. So I think I just have another minute here, but I wanted to take a pause here, and I think we're saving questions for later, right, Audrey? Okay.
Yeah, I think so.
Okay. Yeah, I can let Andy jump in earlier, and we can, because I know this is a very active chat. I was just seeing all the questions come in. So there'll be lots of questions after.
Just for you and Andy, if the track is like distracting, I know sometimes it is. Just I'll pay attention to it and bring back the questions later if it's
perfect.
That's a tricky dynamic. I know sometimes, but thanks so much. That's a great intro. Andy, you want to move on from there?
Yeah, I can jump in. Thanks. I'm just going to share a few slides just for some background. Hopefully everyone can see those okay. So this is just building off that kind of introduction, which is very helpful. This is taken from Health Canada. Every year they do a very helpful, for researchers like me, it's a real gold mine. Just in terms of the data that's provided. And this kind of level of information was not provided, I should note, under the previous conservative federal government. So it's a real asset to have this information and have a federal government that's actively invested in upholding the Canada Health Act. And so you can see in the country, according to reported extra billing, and I say reported because there is a sample or a sampling methodology that's used, and in large part it relies on the provinces to sort of play ball with the federal government and work towards an estimation of what they understand to be extra billing occurring in their province. And so perhaps unsurprising, BC has been cooperating with the federal government. And I don't think the same can be said for other provinces, just in terms of their willingness to engage in these issues. So as you can see, for 3 fiscal years, Quebec didn't report any data. And they still, I would say that their numbers, even though they're second in terms of BC in terms of total extra billing over this 6-year period, I would say, just because of what's been going on in Quebec for a number of years, their extra billing is probably much higher. But that said, BC, based on reported extra billing, continues to have the most significant reported extra billing in the country. And I should note, as was said in 2020, 2021, that fiscal year was the first year that the diagnostic services policy took effect. And this starts requiring the provinces to ensure that diagnostic services, particularly diagnostic imaging, which is the issue here, is provided on a publicly funded basis. It doesn't require private payment. Clinics and physicians are not extra billing for those services. And in 2020, 2021, that was the first year that took effect. So we saw this jump from 13.3 million in the previous year up to 23 million. And things have slightly come down a bit, which is good in BC, but still the total extra billing was 18.1 million, I should say. And of that, the largest share was for, as you can see, in the little box in the top right, the largest proportion of that was for extra billing in diagnostic imaging facilities, and the minority or the smaller share was in private surgical facilities. So these are still significant numbers. Like I said, I think it's an underestimate because of the limitations of how the sampling is done. But nonetheless, it provides a view to the situation in BC as well as the rest of the country. And I should know, just in terms of BC's efforts to get reimbursement. So extra billing these dollars get clawed back on a dollar for dollar basis by the federal government. So the more that provinces allow extra billing to happen, in theory, the federal government, like was said, will claw back those dollars. And BC's efforts to demonstrate its action against extra billing has allowed the province to recoup about $63 million over the last 6 fiscal years out of the $1.1 million or so that was extra billed. So about 60% or so of extra billing in BC has been recouped by the provincial government, demonstrating their commitment to tackling the problem. So that's positive, but we have more work to do. And so this is just kind of reiterating in a number of different ways some of the points that I made. BC, since 2017, has conducted 12 private clinic audits, and these are primarily in private surgical facilities that have had longstanding extra billing problems. And the provincial government currently has a diagnostic audit framework under development. And this is in response to really having to tackle the unlawful extra billing happening in diagnostic imaging clinics. And so the BC government plans to audit 3 diagnostic imaging clinics per year, and for a total of 12 audits. And it estimates that there are 12 private for-profit diagnostic imaging clinics that are engaged in extra billing. So that's why it's trying to work towards those 12 audits. And this is a similar approach that it's taken to the private for-profit surgical facilities. So one of the responses, and I'll talk a little bit more about this, has been from the provincial government to respond to the issue, saying by contracting these clinics to provide publicly funded procedures, this is one of our key strategies of eliminating unlawful extra billing. And actually, I'm just going to pop to this slide, which is an extracted right from the Health Canada annual report that came out just a few weeks ago. And just a few key points. So this is the BC Ministry of Health saying that it has increased health authority contracts with private for-profit clinics or extended additional contracts to private surgical clinics found previously to be extra billing. And the health authorities have moved from short-term to multi-year terms of service. Overall, the ministry views this current productive dynamic between health authorities and clinics and clinics formerly providing private pay services as demonstrative of the value of contractual arrangements to bring private surgical services back into the public system. So this is one of their key strategies of trying to address this persistent problem in BC of unlawful extra billing. And what I think is a concern is that unfortunately in BC, the clinics that have been contracted by health authorities have at various times still continued to engage in unlawful extra billing. So charging patients unlawfully for services that are insured under MSP. The cases, in one case, False Creek Healthcare Center, they did have their contract pulled after they were audited and found to have been engaged in unlawful extra billing. A new owner took over the private center, and the health authority, or actually 2 health authorities, renegotiated new contracts with that facility. In 2 cases, Kamloops Surgical Center and Surgical Centers Incorporated, there were contracts that were maintained and public payments for publicly funded procedures that were provided to those facilities during the time that they were found to be audited and engaged in unlawful extra billing. And then, like we've talked about, the issue of diagnostic imaging clinics engaged in extra billing continues to be a problem in the province. Some of these clinics both have contracts for diagnostic imaging or have had contracts, and others bill MSP directly. And I'm not going to go into all of the details here, but the main issue is because we still don't have a prohibition or a ban on unlawful extra billing under the Medicare Protection Act, private payment and unlawful extra billing in medical imaging facilities is ongoing. And so we're in year 2 now of the provincial government getting federal dollars clawed back based on extra billing occurring in those facilities. The other point to make is that we have seen the provincial government take action on extra billing, and this has been most recently through an out-of-court settlement with TELUS Health. They had a subscription-based private pay primary care service, which through court documents, the ministry hired a private investigator. What was demonstrated in those court documents was there was preferential access to a GP or family physician that required the patient to pay a subscription fee to get that access. And that's contrary to the Medicare Protection Act and what's contained in the Canada Health Act. And then, as I said, there was an out-of-court agreement. So the provincial government obtained an injunction to tell TELUS Health to stop engaging in this activity. They settled out of court. Unfortunately, TELUS Health was not required to pay back the extra billing that it obtained from patients, but the corporation has said that it has changed their TELUS Health Life Plus program. I have to admit I'm a bit unclear on what exactly has changed, but the idea behind it is that they are now compliant with the Medicare Protection Act and will not be engaged in extra billing or alleged extra billing according to the provincial government. The second case most recently is Harrison Healthcare. This came out right around the same time that the provincial government announced that it was taking action or obtaining the injunction against TELUS Health. And as of today, we don't have any indication when there will be a determination or sort of where this stands. But my guess is we'll probably see an out-of-court agreement similar to the TELUS Health arrangement. So more to come on that, but it is just to give you a sense, the province has certainly been concerned about the growth of these subscription based primary care, virtual care programs. And I should also note, BC is not the only province that's having these platforms and corporations really expand. This is going on across the country, and it's also on the radar of the federal government. So I expect we'll see more attention on this in coming years. So just to add, so the BC response to extra billing, as was mentioned, we came out of the Cambie litigation, which was all about extra billing and sort of the unrestricted, creating the unrestricted rights for corporations and physicians to engage in extra billing while also receiving public payment. And so we came out with the Supreme Court of Canada saying we're not going to hear the appeal, and BC's Medicare Protection Act remains intact. And in 2018, before we had a final kind of conclusion to the Cambie litigation from the Cambie Clinic and Brian Day, the BC government brought in amendments to the Medicare Protection Act to strengthen the protections and prohibitions against extra billing. And this was Bill 92. It increased the offense amounts for engaging in unlawful extra billing, and intended to also bring in this prohibition on extra billing for medically necessary diagnostics. And this is what's referred to as Section 18.1 of the Medicare Protection Act. And as it stands today, like I've said, it's not in force. So it's not something that the provincial government is actively enforcing. And in fact, in the most recent Health Canada report, it says that the province doesn't have a date by which it plans to bring it into force. So this means that at this point in time, BC remains non-compliant with the Canada Health Act Diagnostic Services Policy, which says diagnostic services are medically necessary, and you cannot extra bill or charge patients privately for medically necessary diagnostic services. And like I said, my points are a bit out of order here, but we saw action against TELUS Health, and this was coming out of public pressure around patients being asked to pay for access to primary care. We see the Harrison Healthcare negotiations ongoing. And to my knowledge, we haven't seen civil or criminal action taken against private providers engaged in extra billing. I would make the point that in any other sector, we'd probably call this fraud, but it doesn't tend to be labeled or understood in that way. And I think we should consider it fraud. This is defrauding the public we have a taxpayer funded system. These services are medically necessary. Patients should not be having to pay out of pocket for services that are already covered and publicly insured. That was the excerpt I showed you. So just to wrap up, I think one of the approaches that we're seeing emerge in BC and also across the country is this idea that we want to get for-profit corporations and those physicians that are engaged in extra billing to play ball by publicly outsourcing to them. So we get them not to engage in unlawful extra billing by paying them with public dollars for publicly funded procedures. And I would argue, based on the evidence in BC, is that I think this is problematic because we have seen those very clinics, even though they have received public contracts, they still have been found to have engaged in unlawful extra billing. And I think at the end of the day, that's really the business model of a lot of these for-profit investor-owned facilities, is maximizing revenue. And that includes taking advantage of public contracts, but also taking advantage of extra billing and private payment. So I think, it's true that we have maintained our legislation in BC, and the province put up a very good legal defense supported by the federal government of the principles of the Canada Health Act. But we know that access to healthcare across this country is under threat, and it's being challenged, and it requires urgency on the part of governments. So we have those solutions, but they do require the political will, and they require the organizing of groups like the BC Health Coalition and others to ensure that healthcare is based on need, not ability to pay. So that, I would argue, means tackling extra billing head on. It means strengthening enforcement and bringing the Medicare Protection Act into compliance with the Canada Health Act. And that's Section 18.1 of the Medicare Protection Act in BC. And that would help us get a handle and start to tackle the largest share of extra billing in the province, which is now estimated to be in diagnostic imaging facilities. It also means the solutions include looking at system improvement and system redesign, building out our public hospital and outpatient capacity. So single entry referral models where you're referred to a group of surgeons and other providers rather than waiting on individual surgeons' wait lists, and those wait lists can have very different wait times rather than making more efficient use of our resources. Looking at expanding operating room time, which the provincial government here in BC has made a significant effort to do, but I would argue there's still more work to be done. And also addressing the challenges with our workforce crisis. And then lastly, I think being smarter about how we manage and reduce the burden on our hospital capacity, because so much of our ability to deliver surgeries depends on our ability to have the staffing resources and the beds in place for surgeries that require inpatient stays to be completed. And so I think being aligned with the evidence around how we mitigate the burden of COVID-19 as well as other infectious diseases, and that continues to be a challenge across this country. So I'll wrap up there.
Okay, well, thanks, Andy. You answered so many of the questions already in that. But I'll start because I think we've got some folks here on the line who have firsthand experience with extra billing. We've got someone who spent $1,800 on a surgery at False Creek Surgical Center. That's 8 to 10 years ago. And then Laura says cost $17,000 for spinal cord surgery at False Creek, with three MRIs that were over $1,000 each. So maybe for clarification, is that considered extra billing, or like what are the pieces that you would need to know in order to answer that question? And then I think more broadly, like for folks who think you might have been extra billed, like how do you report that, and can you get money back for that? I don't know who's interested in taking that, Sad or Andy.
Yeah, I mean, I think so. Yeah, it's kind of off the top. The question is, how much would MSP reimburse said clinic for a spinal surgery, right? And that's obviously a very technical question depending on the kind of spinal surgery, the length and duration, and the anesthetic codes and the modifiers, et cetera. But depending on how much MSP would reimburse, any amount on top of that would be considered extra billing. And so, you know, as kind of Andy was saying, is like we are like in the case of False Creek, MSP won't reimburse it at all. But I think just broadly speaking, the idea is the government is trying to contract to these private entities as a way of going around this whole extra billing thing, right? But just to go back to the definition of extra billing, it is any number on top of what our publicly funded system would actually reimburse. Same thing for the MRIs. So I don't know if Andy, you want to add anything on to what I just said about the surgeries, but yeah, just to be very succinct. Yeah, like you can choose to pay, like I think something that to add a little bit more nuance, or I guess complications to this discussion, like there are unenrolled physicians. So physicians who deliberately do not take part in public Medicare, that you do have the ability as a physician to opt out of Medicare. And so people, it's more common in Quebec, for example, but you can actually go to a unenrolled physician and pay. The majority of people don't choose to do that. It creates a lot of complications, logistical complications, because then that person's having to refer, and it just becomes really unwieldy. But that is an option.
I think in BC there's less than 10, so it's really a very small minority. Which is why
it's a small minority of people.
Yeah,
which is why they engage in other tactics, right? So it's more common in Quebec, as I was saying. People might also start hearing about certain cases where some private clinics are flying in physicians from other provinces who have a license to work in BC, but they're unenrolled as well. There's a lot of little loopholes, and it's a bit of a cat and mouse game where things might not be technically illegal, but they're still against the spirit of Canadian Medicare and the Medicare Act. But yeah, I would say if you've paid out of pocket to go to an unenrolled physician and kind of opt into the private system that way, that you wouldn't be reimbursed for it. And as I said earlier, the piece about extra billing stands. Anything above what MFP reimburses.
I mean, I would add, if you have been extra billed, it should be reported if that physician is enrolled.
And there is a better system now, I think, on the MOH's website. Let me look for the link.
It would go in as a complaint, and they would collect kind of the evidence surrounding the transaction. And it would also, I think, inform them of, right now in BC, they don't audit all clinics. They don't endeavor to audit all clinics. They take what they call a risk-based approach. And basically, where they have an understanding of extra billing occurring, they prioritize audits of those clinics. So any information that would help tell them where there may be extra billing occurring, I think is really good to get it on the record. So I would encourage you to send that to the ministry, and it's I can find the link if folks are interested.
Well, thanks. Well, we've got a couple questions about the role of the provincial government. So Anna is asking, how is it that in BC, where the government elects suggest they support public services, how are they engaging in this behavior? Maybe this is a good chance to reflect on the delays to enforcing the Medicare Protection Act that can be brought, but also like what the timeline could have looked like after, or what we're looking at now. Andy, I think this is a bit in your wheelhouse. What can you say about the way the provincial government is addressing this issue? You've said some, but you want to give it another shot?
Yeah, so I mean, I think I covered it a lot. I think on the one hand, we've seen some really welcome action taken against extra billing, and a big part of that in BC over the last 5 or 6 years or so has been certainly building out public MRI capacity. It is true that BC had very limited public hospital MRI capacity compared to other provinces. And that's where a significant amount of extra billing has historically been occurring. So the province, recognizing that, has done a lot to invest in public diagnostic imaging capacity. And obviously, I think we're now at the point where, by bringing 18.1 into force, the Medicare Protection Act provision that would explicitly prohibit extra billing in diagnostic imaging facilities, it's kind of the culmination of this 5 or 6 year effort by the provincial government to try to tackle extra billing in medical imaging facilities. So I think we've seen that, and I think so just in terms of building up capacity. And then I think it just requires an ongoing effort around enforcement. I think building up that capacity, the Ministry of Health's billing integrity program and audit branch is still very under-resourced. They don't have a lot of capacity. I've been tracking this for a long time, and it's some years they only have been able to conduct like one private clinic audit a year. And so to not have more capacity to that is, I think, quite unfortunate. So it would send a signal if the capacity within the government was increased to tackle the issue head on. And then I think what is a concern to me is what I shared, which is the approach seems to be, the province thinks that they will kind of address extra billing through increased outsourcing to these private for-profit facilities. But what the evidence shows in BC, and what we're seeing in places like Ontario as well, is that the business model depends on a mix of public and private payment. And so they're quite happy to take public contracts, but we have continued to see unlawful extra billing occurring even when those facilities are contracted by health authorities. So I'd like to see that practice stop. I think we need to build out the capacity in the public system so that we can wean the province entirely off of these investor-owned clinics.
Yeah, I just put in the chat, there's a just released report from the Ontario Health Coalition that just looks at specifically that dynamic. And while the Ford government had promised that contracting out to private clinics wouldn't lead to people having to pay out of pocket for for care in those facilities, there's a lot of evidence and growing that that's not what's going on, that the clinics under contract are illegally extra billing. So it's not a strategy to prevent the extra billing, at least as we're seeing in Ontario now, and in BC, there's evidence in that towards that as well. Well, we've got just 5 minutes left on the hour, and I think this conversation often gets very technical about what's extra billing and all of that. But maybe as a way of closing, you can I'll invite both Andy and Saad to reflect on like why this matters and how it goes back to the principles of equitable access. I think there's some comments in the chat. These questions that we hear a lot, like why not pay privately if you can afford it? Rich people are doing it. Why have this barrier for people to choose that? Yeah, like what can we just like end by thinking about like what's the end goal here, and I think Cambie gave us a lot of evidence around like a two-tiered system and people jumping the queue, but yeah, like I think it's important to remember that it's not just about someone maybe paying $300 for an MRI extra. Like, what is it really about? Saad, do you want to start us for this one?
Yeah, I think, I mean, the international evidence has shown, and this is not necessarily the discussion we're having today, right? We're not talking about a two-tier system. Certainly, we're talking about loopholes and little ways that some entities are trying to utilize illegal extra billing to make a couple of bucks or more than a couple of bucks. But what I think, when it comes to two-tier healthcare, like the international evidence is clear, and it leads to worse outcomes for the public system and worse outcomes for those who can't pay. And so really, my motivations for being in this discussion is, as I said in my opening statement, that it's about equity in access, and that all Canadians have access to high quality healthcare, and it's not based off who has the ability to pay, but actually based on need. And when we have people who are able to jump the queue, that oftentimes leads to worse outcomes for all of us. So that's kind of my take on all that. Can let Andy speak to it. So,
yeah, I mean, I think the big issue here, and just to build on that, is it's an issue of the workforce, and healthcare professionals, healthcare workers can't be in two places at once. And so we have an abundance of empirical evidence, and much of it was debated and discussed through the Cambie trial around the problems of a private pay tier where access is based on your ability to pay. And what happens is those physicians and surgeons will migrate into the sector where they can deal with the less complex patients and often earn more money. And it's certainly not all providers, but the investments where you attract corporations and private equity firms and lots of investors, that's where the dollars will flow. And so you're gonna stretch and strain the system that those of us depend on, where we can't pay thousands of dollars for medically necessary care. So the public waiting times increase, and that's what you see in two-tier systems. With inequitable access, wait times grow for those in the public system who depend on the public system, and outcomes decline. So I think, that's the main issue. And I think, just to add, I think the more that we see the kind of the corporate involvement and entrenchment into our public healthcare system, the more that we're likely to deal with another Cambie litigation. Let's not forget that the Cambie, over about a decade or so of litigation that tied up the provincial government, arose based on issues related to unlawful extra billing that came to light. And so the more that we continue to sort of bolster and prop up a corporate investor-owned sector, the greater likelihood that we're going to be dealing with these same actors again and again and again, who have been quite determined to kind of undermine the foundation of healthcare based on need, not ability to pay. And so, the more that we have their involvement in delivering diagnostics and surgeries, the more they become a powerful corporate lobby. And that's precisely what we see in the United States, where you see very powerful corporate and investor interests in healthcare. And they have really been able to influence legislation, standards, quality of care, and it is not in the public interest. It is serving their profit margins. So I think we need to be careful about understanding that it's not just one private pay MRI or one private clinic, but the more that we allow this behavior to continue without a focus on the public solutions, the more that it becomes a threat, I think, to the very foundation of public Medicare in this country.
Well, thanks. Thanks for those thoughts as a closing. I think we're another big part of this conversation that we need to remember, and another part of our work at the Health Coalition is really that work of like, how do you improve the public system so that there are those resources to have timely and quality care for everyone. And as you've both said really clearly, the evidence shows that that's the best way to provide that is through the public system, but that's not defending the state of the public system now. So I think maybe we need another lunch and learn on the list to just dive into those public solutions and all of the evidence that's out there about what models and changes we can bring in to improve the access even in the public system. That's for another day. I know you could probably both say lots about that, and maybe if folks are interested, I know the Canadian oh my gosh, I'm blanking, SOD. Canadian Doctors for Medicare. You've done a Better Medicare webinar series as well, and there's been some really good sessions there. I don't know if they're available, but if folks want to look into it, it's also great conversations about public solutions that I've been following a bit there. So I recommend it to everyone. So I think we're at time. It's 1 o'clock. I want to thank again Andy and Saad for taking the time to talk with us today. Thanks for coming. I hope you'll come again for a future lunch and learn or something else. And thanks for everyone for joining us today. I think we'll leave it there for today, and be well, everyone. Take care.